We're live. This is Brother Wolf, and hi, Rosaline. I'm going to be hosting the slides just in case we have any internet connection problems and people drop off. So I'll host the slides tonight. So make sure everyone clicks on my box. So tonight is Group 6, and we're going to be talking about hospice and palliative care. And so I am going to turn it over to them, and give me 1 minute to do the screen share.
Sorry.
It's no problem. Listen, I understand completely. I've been doing this long enough that I know the internet doesn't always help us. So I'm going to do present. So you guys tell me, can you see the first slide, and does it look large enough?
Yeah, we're good.
Yeah.
Okay, good. Well, I'm going to turn it over to the group whenever you guys are ready.
All right. Since I've got the first couple slides, I'll just start. So we're doing managing hospice care organizations next. So just a basic hospice definition. It's basically a place that provides care for those who are terminally ill or will basically pass away. Next. And so hospice care, hospice patients and their families are cared for by a team of doctors. I lost it. A team of doctors, nurses, social workers, counselors, aides, spiritual caregivers, therapists, and volunteers working together in a team to address the patients' and families' identified needs. In addition, hospices help provide medications, supplies, equipment, hospital services, and additional helpers in the home as appropriate. Hospice nurses and physicians are experts in the latest medications and devices for pain and symptom relief. In addition, physical and occupational therapists assist patients to be as mobile and self-sufficient as possible, and they're often joined by specialists schooled in music therapy, art therapy, diet counseling, and other therapies. Next. And so palliative definition, the basic what it means is it's basically something that reduces the effects or symptoms of a medical condition without curing it. Next. And so the care for this would be a multidisciplinary approach to specialized care, medical care for people with serious illnesses. It focuses on providing patients with relief from symptoms, pain, physical stress, and mental stress of a serious illness, whatever the diagnosis. The goal of such therapy is to improve quality of life for both the patient and the family. Next. So the difference between hospice and palliative, the similarities are that they both share a common goal in providing symptom relief and pain management, and then the differences would be that palliative care services can be offered to any patient without restriction to disease or prognosis, and hospice care is used for people with no further option for curing their disease and will eventually pass away. Next.
Okay, that's me. History of hospice care. Hospice has the same linguistic root as hospitality, which is from back to medieval time. It refers to a place of shelter for those who are sick or traveling. The term was first used to specialize care for dying patients by physician Dame Cicely Saunders. She began working with terminally ill patients in 1948. And in 1963, she visited Yale University and introduced the idea of specialized care to the dying to the United States. And during her lecture about hospice care to the Yale University, Saunders showed the nurses, medical students, and the chaplains pictures of cancer patients, showing a huge difference before and after symptom control care. And in 1965, Florence Wald, who was at the time the dean of the Yale University of the School of Nursing, invited Saunders to become a visiting faculty member of the school for the spring term. And in 1967, Saunders founded St. Christopher's Hospice in the United Kingdom. Next. In 1968, Wald took a sabbatical from Yale to work at St. Christopher's and learn all she could about hospice care. In 1974, Florence Wald and two pediatricians and one chaplain founded Connecticut Hospice in Brantford, Connecticut. And in 2005, the NHPO hosted the first national conference on access to hospice and palliative care. And also in 2005, the number of hospice provider organization tops 4,000 for the first time throughout the country. So Florence Wald was a pioneer in the field of hospice care in the United States, and she died in 2008 at her home in Connecticut. Next. And hospice care, it focuses on caring, not curing. So it is provided in long-term care facilities like nursing homes, freestanding hospice centers, and hospitals. Next.
Okay, who pays for hospice care? Hospice care is paid for by Medicare, Medicaid in most states, the Department of Veterans Affairs, most private insurance plans, HMOs, and other managed care organizations. Also, community contributions, memorial donations, and foundation gifts allow many hospices to give free services to patients who can't afford payment. Some programs charge patients according to their ability to pay. Next. Medicare is the largest payer of hospice care. In 2011, they paid 84%, and in 2010, 83.8%. Next slide. The role of CMS in regulating and reimbursing hospice care. Hospices must meet conditions of participation to become licensed and certified by state regulators, and to be allowed by the Centers for Medicare Services to continue to participate in the Medicare hospice program. Without certification as meeting these standards, hospices cannot receive reimbursement for enrolling patients in their program. In order to qualify for hospice coverage under Medicare, a physician must confirm that the patient is expected to die within 6 months if the illness runs a normal course. If the Medicare patient lives longer than 6 months, hospice coverage may continue if the physician and the hospice team recertify the eligibility criteria. The Medicare hospice benefit affords patients 4 levels of care to meet their needs. They include routine home care, continuous home care, inpatient respite care, and general inpatient care. Next.
All right, so the 4 levels of hospice care. Routine, number 1, routine home care, where most hospice care is provided. Number 2, continuous home care, which is furnished during a period of crisis and primarily consists of nursing care. Number 3, inpatient respite care, which is short-term care and intended to relieve family members or others caring for the individual. And number 4, general inpatient care, which is short-term and intended for pain control or acute or chronic symptom management, which cannot be provided in other settings. Next. Medicaid's role in hospice care. Hospice benefits are optional state benefits of Medicaid that include an assortment of different services to terminally ill individuals. These services include nursing, medical social services, physician services, counseling services to the terminally ill individual and the family member or others caring for the individual at home, short-term inpatient care, medical appliances and supplies, home health aid and homemaker services, physical therapy, occupational therapy, and speech-language pathology services. Individuals must elect the hospice benefit by filing an election statement with a particular hospice. They must acknowledge that they understand that other Medicaid services for the cure or treatment of terminal condition are waived. Individuals may, however, revoke the election of hospice at any time and resume receipt of the Medicaid-covered benefits waived when hospice was elected. Hospice provider must obtain a physician's certification that an individual is terminally ill, and hospice services must be reasonable and necessary for the palliation or management of the terminal illness and related conditions. A hospice plan of care must be established before services are provided. Next. Medicaid financing and reimbursement. The Medicaid program is jointly funded by the federal government and states the federal government pays states for the specified percentage of program expenditures called the Federal Medical Assistance Percentage, FMAP. FMAP varies by state based on criteria such as per capita income. The regular average state FMAP is 57%, but ranges from 50% to wealthier states up to 75% in states with lower per capita income. The maximum regular FMAP is 82%. FMAPs are adjusted for each state on a 3-year cycle to account for fluctuations in the economy. The FMAP is published annually in the Federal Register. Next. State payment of Medicaid. States must ensure they can fund their share of Medicaid expenditures for the care and services available under their state plan. Recognized sources of funding for the state share of Medicaid payments include legislative appropriations to the single state agency, intergovernmental transfers, certified public expenditures, permissible taxes, and provider donations. Before CMS approves a state plan amendment, they must verify that state funding sources meet statutory and regulatory requirements so they can authorize federal financial participation for the covered services. Next. Service delivery and provider payment rates. States can establish their own Medicaid provider payment rates within federal requirements. States generally pay for services through fee-for-service or managed care arrangements. Under fee-for-service arrangements, states pay providers directly for services. States may develop their payment rates based on the cost of providing the service, a review of what commercial payers pay in the private market, and a percentage of what Medicare pays for equivalent services. Under managed care arrangements, states contract with organizations to deliver care through networks and paid providers. Approximately 70% of Medicaid enrollees are served through managed care delivery systems where providers are paid on a monthly capitation payment rate. Next.
The professional and advocacy organizations. There is a list here. The American Academy of Hospice and Palliative Medicine is an advocate for palliative medicine physicians and professionals for the relief and prevention of patient and family suffering. The American Board of Hospice and Palliative Medicine is a professional organization for the promotion of high standards of physician competence for the care of patients with advanced progressive illness. The Center to Advance Palliative Care is also a professional organization dedicated to providing hospitals and other healthcare institutions with quality palliative care services. The National Association for Home Care and Hospice is an advocacy organization for home care and hospice caregivers. The Home Health Care Nurses Association is an affiliate professional nursing organization of the NAHC for home care and hospice nurses. And the the Hospice and Palliative Nurses Association is the oldest professional nursing organization dedicated to promoting excellence in pain management and end-of-life care. Next. And the big one is the National Hospice and Palliative Care Organization. It's the largest advocacy organization representing hospice and palliative care programs and professionals committed to improving end-of-life care and making hospice care more accessible. The organizational structure of typical hospice care is that a family member serves as the primary caregiver and helps make decisions for the terminally ill individual. Members of hospice staff make regular visits to assess the patient and provide additional care or other services. And hospice staff is on call 24 hours a day, 7 days a week. Next. Continuing this, the hospice team develops a care plan to meet patient individual needs for pain management and symptom control. And the team consists of patient's personal physician, the hospice physician or the medical director, nurses, home health aides, social workers, clergy or other religious counselors, trained volunteers, and speech, physical, and occupational therapists if needed. And then the interdisciplinary hospice team manages the patient's pain and symptoms, assists patients with emotional, psychological, and spiritual aspects of dying, provides the needed drugs, medical supplies, and equipment, coaches the family on how to care for patients, delivers special services like speech and physical therapy when needed, and makes short-term inpatient care available when pain or symptoms become too difficult to manage at home or the caregiver needs respite time. And they provide bereavement care and counseling to surviving family and friends. Next.
Okay, the hospice care industry. The hospice care has revenues of around $31 billion per year in the United States. In 2011, 1.65 million patients received hospice care services. There are approximately 450,000 jobs in the United States in hospice care, and there are approximately 5,300 hospice organizations across all 50 states. Next slide. The hospice organizations in southeastern Idaho include several organizations. They include Alliance Home Health and Hospice, Hospice of Eastern Idaho, and Hands of Hope Home Health and Hospice. And Hospice of Eastern Idaho is the only nonprofit hospice in the area. Next. And that's the end of our presentation.
Excellent. Can you hear me okay?
Yes.
Yes.
Good. So very well done. I'm going to leave them. I'm going to just go through and highlight some of these slides. You guys did a great job here. I think this was a good slide. Yeah. Well, let me go back to this one. So palliative definition, I think it was good that you guys pointed out the difference between hospice and palliative care, and you did a good job there, because palliative care can be, it's really symptom relief, right? It's trying to help somebody get some sort of relief or comfort, hiding the pain, diminishing the symptoms, making the patients more comfortable, or relieving suffering. So that's really what palliative care is, whereas you correctly identified in this slide here that the main difference is that hospice is used for people where they really have no other options. So palliative care can be given to somebody who you might also be treating to kind of solve the condition or mediate the condition, whereas in hospice, it's if the disease follows its normal course, they will pass away in 6 months. So that was really good. You're correct about Medicare being the largest payer. And then I also wanted just to, you guys came up and found some great organizations, so I'm glad you included this slide here. And then I'm also glad that you kind of emphasized that this is the main organization here for hospice. And keep in mind that this course is managing healthcare provider organizations. So these other groups that you mentioned are really important for the professionals and medicine, the physicians, and those that are involved in providing care, the nurses, etc. But as far as the actual organization goes, so if you are working for a hospice organization, they're most likely to belong to this organization here, the National Hospice and Palliative Care Organization. You also talked about Medicare's role. Let's see, did I pass that? That was earlier. Yeah, here, this is a really important slide, talking about the physician has to certify and prescribe. That's a requirement under Medicare, and he or she has to certify that they have 6 months or less to live. So those are really important requirements to keep in mind. Other than that, you guys did a really great job, and I don't have anything else to add, so I'm going to just exit out for a moment and see if you have any last-minute comments or questions. I'll ask you if somebody, let's see, I need to stop sharing. If one of you would be so kind as to post your slides in the student chat board like you've seen in previous weeks, and then as a group just monitor that chat room and make sure see if people have questions or comments. You could also pose questions to make sure they're reading your presentation and that sort of thing, and then I'll post the link to the recording. So great job. Any last minute comments or questions?
No.
No, I don't think so.
Okay. Excellent work. Thank you so much. Have a great night.
All right, thank you.
You.